pain. I was worried about where I was going, and then I just slowly started to follow people that were in more and more PT. I liked it. Okay, it was easy to find. So today we're going to talk about herbal products and how they can be used in pain. We'll talk about some of our topicals. We'll have the chance to try some of our topicals, and then we'll talk about NSAIDs for the last hour there. Okay? Any questions before we get started for today? All right, abbreviations are going to be in the front again. These are my thoughts. We got an email this morning at AMC saying make sure that you guys aren't selling certain products, so we'll talk about that today. These are my views, not the government's. All right, the objectives are listed there. They are in the syllabus as well. So like I said, we'll talk about herbals, topicals, NSAIDs. We'll kind of wrap it up and talk about some other resources as well. Looking back at that list of some of our pain meds, again, this is just another way to look at it. These are the three we're going to be focusing on today. So with supplements, do it, don't. Guidelines say, okay. So this is a snippet from some of our osteoarthritis guidelines, but really it's up to the patient and the clinician and their kind of relationship and what they decide to do. So there's really no like, yes, absolutely do this, or no, absolutely don't. But one thing that we do need to be mindful of whenever we're talking about herbals and supplements is that agents are not regulated by the FDA. Okay? So if you have a product that has fish oil in it, that's over the counter, we don't know if there's fish oil in it. You can have a product that says it's one supplement and it might not even be in there. Okay? So there are different ways that look at the accuracy of what's in there, not necessarily if it's helpful. Okay? So you can look for different seals. They're all independent folks that are doing these reviews, these organizations that are doing these reviews, making sure that it is the appropriate product that is in there, not necessarily saying that it's effective or safe for that treatment. The main ones that we'll look at today are going to be alpha-lipoic acid, fish oil, glucosamine, magnesium, in this case glycinate, but any magnesium is fine, and then turmeric. And so we're just going to dive into each of them. So alpha-lipoic acid comes from a lot of our organ meats, spinach, broccoli, tomatoes. So if someone has a balanced diet, they probably don't need a supplement with alpha-lipoic acid. Okay? If someone says that they only eat Big Macs and that's it, are there tomatoes in it? Are you getting those? You spitting them out? Eating those pickles? Okay, so if they're having a balanced diet, they probably don't need to add this on. It's going to be a free radical scavenger. What other diseases do we think about free radical scavengering? Some things. What about like cancers? Some of those things, right? Some of our routine things. Primarily, we're going to use it for our nerve pains. The dose is going to be anywhere from 200 to 600. I do not expect you guys to remember the dose. It is lipophilic, and the side effects are mainly going to be GI upset, and it can actually lower your blood sugar. So how I remember this one is in our patients that maybe have diabetes. How good is their diet?
Bad.
Not great, typically. Okay? What types of pains do they have? Nerve pain. Okay? And what do we want to help with them? With their sugars?
Lower them.
We want to lower it. Okay? So you guys already know this stuff. Okay? Wow, look, all the things that are on there. Got it. This is an example of an OTC product, Nervive. I personally don't love branded products, as we will talk about when we go through topicals. So Nervive, you can actually see in the supplemental facts, it has alpha-lipoic acid. I don't think my cursor is going to work on this. It's not. But on the side, we have all of these different things. We have alpha-lipoic acid at 600, and then we have all of these other nerve relief herbal blends. What? Look at, I'm learning so many things. There you go. Okay, right here, this nerve relief herbal blends. And what are some things that we see in there? Turmeric. Okay, we'll talk about turmeric in a few more slides. So is it really the ALA or is it turmeric that is giving these folks benefit when they're taking Nervive? All right, next one, omega-3. We talked about omega-3 a little bit yesterday when you guys were talking about your cholesterol stuff. So it does come up again in pain. Typically, it's going to have anti-inflammatory effects. And again, it's found in all of those fish products. Walnuts and chia seeds as well are some of the natural sources. It's going to look at cholesterol. Again, we're lowering that triglyceride is the main thing. Side effects is though that it's going to increase that LDL. Okay, so same things as yesterday. That fishy aftertaste, GI upset. This one can also increase our bleeding risk. Okay? Glucosamine is made from shells, or it's lab created. So if someone has a shellfish allergy, should they take this? Ooh. Okay? It's extensively metabolized by the liver. It has lots of drug interactions. It is also one that increases your bleeding risk. Just flying through these ones here. Magnesium. We talked about magnesium yesterday. We already know the mechanism. Okay, so it's NMDA receptors. When they are stimulated and we get that calcium influx, right? We get that action potential going along. Magnesium acts as a plug on those NMDA receptors so we don't get that calcium influx. Okay, that action potential is reduced. Typically, we're going to see this in our migraines or muscle cramping, fatigue type situations. Naturally, it's going to come from the diet. There are different formulations. So glycine was the one that was called out. That one does have the most pain data associated with it, and it has high bioavailability. Oxide is the cheaper one. Okay, folks can find oxide really, really cheap. However, it has low bioavailability. So where does that stay in your body? In your gut. Okay. If you have a lot of magnesium in your gut, what side effect are you going to get? Diarrhea. You guys know it. See? If you have too much magnesium in your systemic circulation, you're at risk of cardiac issues and cardiac palpitations. So that will be the counseling point of that one. All right, turmeric, the last one of the group. We have anti-inflammatory effects. So it works at our tumor necrosis factor. It is mitochondrial driven. Lots of different things that are happening. Specifically, we're going to use it in our arthritis, our inflammation, our tendonitis, all of those types of conditions. Our dosing is going to be divided throughout the day. Pharmacokinetically, that has really poor bioavailability alone. So it needs to be taken with something that is fatty or with a black pepper component. So oftentimes you'll see them formulated and advertised turmeric with black pepper. This one also increases our bleeding risk, so be careful in those folks. And it can also be a concern for those that are prone to getting kidney stones. Has a lot of GI upset, and it does have some hepatotoxicity. There's been a few more case reports. There's actually recently something on 60 Minutes or one of the nightly news things of a gal who was taking over 2 grams a day, had really bad hepatotoxicity from it. All right, so we talked about a couple of them. Some of them make you bleed, some of them don't. How do I remember them? The core 5 Gs. So garlic, ginger, ginkgo, ginseng, and glucosamine. Glucosamine is our pain one that falls into that. However, fish oil and turmeric also fall in there. Willow bark is actually the metabolite of aspirin. And wintergreen also goes to that same thing that is the metabolite of aspirin. Okay, so those also increase our bleeding risk. So when we're thinking about all these things, we need to be thinking of who are the patients that have a baseline bleeding disorder? Are they at an increased fall risk when we're giving them any of these increased bleeding medications? Are they on NSAIDs? Are they on antiplatelets? Are they on NSAID? For you guys, and should you guys be supporting our military folks, Operation Supplemental Safety is a really nice and handy website to use. They have the availability for you guys to look up certain products to see like, oh, I got this protein powder, how good is it? And it kind of has you go through the different steps of how safe does it appear to be. If you wanted to take a supplement, you can see if there's data on it, see if it's contraindicated for you guys. So that is a good tool. I encourage my patients to go to it if they are very into the different supplements and herbal products. Within that, we also have kratom. Kratom should not be recommended. is my personal viewpoint, as my disclosure slides said. So kratom is something that the military cannot take. It is one of those things that is a no-no. It is not classified as a controlled substance, but the DEA does classify it as a drug of concern. Okay, so it's not regulated. Its mechanism is that it's an opioid. It also works at alpha-2. It also works at COX. So all of these mechanisms that are helpful in pain that we'll learn about in the next 2 days here. It helps with our general pain perception or nociception. It comes in different types of veins. So there's red vein, green vein, white vein. Typically when patients are telling me about it, they're like, oh, I take 5 grams of white, or I take 4 grams of red. And the whole time I'm just like, yep, great, keep telling me all this stuff, and I'm gonna look it up once we get back, because this is something, right, that we don't know a lot about. But patients, when they're taking it, they really know what vein it is, how much they're taking, when to take it. So some have more sedative effects, some have more stimulant-like effects. It extensively goes through our CYP enzymes, and so that is a big thing to think about when we're thinking about drug interaction. And because of that opioid effect, we do have addiction and overdose risks. It does also carry a cardiotoxicity risk. So, Shaver, where do people get this? So these are some sites, right? Again, I'm not telling you guys to do this. This isn't in your slide deck. But these are some sites. Just go around San Antonio. There's lots of these kind of dispensaries that you can go to. And don't worry, veterans get 10% off. Right? Advertise right there on the storefront. So lots of different places. Okay? It's about $2 to $4 a gram. And so patients typically are taking, the ones that have told me, 5 to 15 grams a day. Okay, so it does get pretty expensive for these folks. But there's a ton of resources out there. Okay, my favorite one's that first one, that's why I put it first. But that's just me. Always make sure that you're confirming the validity of the sources that you're using. Okay. So supplement database sounds good and trustworthy. It's really just like a storefront. Okay. So that first one there, this is an example of what it looks like. So you kind of go to the landing page. Both patients and providers can access it, so it's not restricted. You don't have to log in to use it. But then you can type in your product, and this screenshot says that there were 279. This is about a year old, so there may be more products that are listed here. So then maybe you look up turmeric. Okay? You want to know what it's about, you want to know how it works, you want to learn all of those cool things. There's a section for patients, and then there's also a section for healthcare providers. So you guys can see the more nitty-gritty. You can actually look at the studies. They're all hyperlinked in there. Bleeding risk, pregnancy, all of those things are listed for you. So I encourage you guys to check that out should you need something. Clinical pearls, right? Remember that supplements and herbals are not regulated by the FDA to the same scrutiny, and that products need to have a trusted seal of approval or be from an accredited source to verify that integrity and quality. And then making sure that we're evaluating both the patient and the medication for specific factors. So how's it working? What are the drug interactions? What are the precautions and those side effects? Questions on herbals? Alright, topicals. U.S. market continues to be driven by preference for over-the-counters as far as it relates to a lot of our analgesics. So topical analgesics account for what percent of the 17.8 billion U.S. analgesic market? Ooh, okay, we're at least over 5. We're in the 30s, I'm hearing. Okay. Let's go about 9. Okay. How expensive are topicals?
Pretty expensive.
Kind of depends.
Relative to.
Okay.
They're usually not great.
So when we think about topical versus transdermal, okay, topicals are going to act locally. I put it on my shoulder, it acts at my shoulder. Okay. So topicals work at the site of where you apply it. It's going to work by passive diffusion through those layers of skin. It's going to target the nerves that are right there and have its action right there. Some examples would be sunscreen, right? If I put sunscreen on my knee, it's not protecting on my shoulder, okay? But it is absorbing into the skin to have effect. Bug screen or bug spray. hydrocortisone spray. Okay? Again, if I put steroid on my knee, I'm not going to all of a sudden get immunosuppression throughout my whole body. Transdermal, however, is going to be systemic circulation. So it's variable as far as where you apply it, but the goal is to get absorbed into the bloodstream. Okay? So it's going to somehow disrupt the skin layer, or the forces that are within the product itself are going to be able to carry it as a vehicle through all those layers into that bloodstream. Okay? What are some examples of transdermal products?
Nicotine pouches.
Scopolamine, fentanyl.
I have like lidocaine pouches.
So lidocaine, let's think about, is it topical or transdermal? If I put lidocaine on my shoulder, is my whole body going to feel good? Right, I wish, but it's probably not. Okay? I've heard another one. Nicotine, yeah. Right, nicotine, throw it on the shoulder, gets into that blood supply. So fentanyl, nicotine, scope, testosterone gel is another one that's pretty common. Okay. All right, pros and cons of using topicals. So if I have shoulder pain, I just want to treat my shoulder pain. If I have knee pain, I just want to treat it. So it works at the site that you're placing it. Less systemic concentrations, less side effects, less of this ebb and flow, peak and trough that we get with a lot of our systemic products. Less abuse potential. Typically, more compliance. I always question that, but that's what the resources say, that patients are more compliant. I always think that it's typically harder for a lot of patients to remember to put a topical on. Less drug interactions and less first pass. Cons is that you're going to probably have more of a local reaction than you would otherwise. And there's variability as far as if I place it on the palm of my hand, if I place it on my elbow, if I place it on my knee, if I place it on my ankle, based on how big that skin and all the different layers of skin are. What makes a good topical? So what's going to get it to absorb into that site? You want the skin to not be as thick, right? We want to decrease that physical contact. Okay, so we want it close to the surface as far as where we're trying to treat it. We want the skin, if the skin is less integrity, okay, if we have a giant wound and we put a topical, is it going to work? Very well. Okay, do we want that? Not really. But that's how we're going to increase that absorption. Okay. Skin hydration, the more hydrated skin is, the more likely that topical is going to get absorbed. And then increase blood flow. So if we do any of these things with the topicals, or if we do all of these things with the topicals, are they going to be at more risk or less risk of having systemic side effects? If we have really thin skin, if we have a giant wound, if the skin is super hydrated, and we have all the blood going there, that drug is going to go straight into the bloodstream. Okay? So those are all important factors to think about if a patient presents and has side effects of one of these drugs. Did they have one of these complications? Okay, lidocaine will commonly see is used for burns. Is that a great thing if their skin integrity is not intact? And now we're getting systemic lidocaine, which you guys already learned about not too long ago. Okay. So for pain, there's a huge placebo effect when we're using topicals. There is a benefit of rubbing where it hurts that we can see. And we also know that whenever we tell a patient, you know what, I think this is going to help with your pain, and I expect this is going to help reduce your pain, reduce your flare, reduce the severity, we know that it's going to help them, regardless of what it is. If you have that expectation and you have that counseling, it will help them. Okay? It does also increase our patient's involvement. So before I spend a ton of time trying to help a patient change this or change that, I look when the last time they refilled their lidocaine or diclofenac gel was. Okay, if they filled it 6 months ago, they're like, oh yeah, I use it every day. Tell me more. Tell me more about that. How are you using it? How helpful is it? How much are you applying? Okay. So again, we're working at the site of injuries where these are focused on. We're not trying to treat the whole body with these products. So our mechanisms are really going to target some of these neurotransmitters, these prostaglandins, all these different areas at that peripheral site. So the layers of the skin going all the way back, okay? Very top level is the epidermis. That's going to be the waterproof level. All of our key skin cells are going to be in there, and they do play a role in that transduction of that pain signal. So a lot of time we're just like, oh, it's the outer layer of the skin. There are cells in there that are doing things and sending signals. The middle section is that dermis. We have the top layer of that has our nerve and touch fibers and touch receptors, and then the bottom layer is going to be that reticular dermis, and that also has some of our nerves. The very bottom layer of all of those are going to be our hypodermis, and that's going to be that fatty sub-Q tissue. So again, those cells that are in that very top level, these guys, they have a ton of activity. Okay? They help in local inflammatory processes, excitatory factors. They also have sensory, or they have contact with those sensory afferent neurons that are going upward toward the spinal cord, sending that signal up. A big role that they play, that we'll talk about with many of our agents, is that they actually work on these TARP thermoreceptors. Okay? We have some that are warming when they're activated, and some that are cooling when they're activated. And what are some products that you can think of that are maybe warming or cooling when you put it on? Icy hot, biofreeze, right? All these things. See, you guys already know. Okay. Menthol. Menthol, also peppermint, is where it's going to be extracted from. Commonly, it's going to be found in biofreeze. It's a very strong minty type odor. It has counter irritation at the site, and meaning that it increases blood flow to the site, causes vasodilation, and it does also work on A1 and M8. Okay, those are both going to be cooling. Before I keep going, on the sides of your tables in the middle here, there should be a half sheet of paper. Take one and pass it down. So on these half sheets, one side will have all the products that we're going to go through. I apologize they're not in the exact same order that I'm presenting them in. Right? So one side is going to have all these products that we're going to go through. On the other side are all of the products that I have brought today. Okay? So as we go through, I encourage you guys, as we're lecturing about these things, think about this product, think about where it might be most helpful. See what number it is, A through G, or H. And then write that in, right? Left knee, H. Left elbow, E. Right? Whatever you want to do. Okay, so then when we go into the topicals piece, you're not having to try to decide, oh, what is this, where do I want to put it? You'll kind of already have that game plan done. Okay? So menthol is in a couple different products. The ones that you have available today, it's in 3 of them. Okay? The concentrations vary from, what's the highest? 11% down to 5 point something. Okay? Beautiful. Okay? So menthol, peppermint, it's going to be cooling. Camphor, commonly we think of Sarna and Tiger Balm. It also does that counter irritation. It has that vasodilation, that blood flow is going to the area. But we see V1 and V3 activation, which is warming. But we do also see this mixed response of M8 activation, so a cooling, positive, and then we actually see an inhibition of A1. So we have a mixed response, but mainly we think of it as a warming agent. Camphor is one in that it does have a toxicity to it. So it's capped, its concentration is capped in the United States at no more than 11%. So one of the products that you can try today is going to be a Tiger Balm lookalike, and it's 11% menthol, 11% camphor. Okay, so that's the highest concentration of camphor that we can use in the U.S. There's been case reports of kiddos that use it, right, using it like a Vicks VapoRub type product. Pets, licking, getting into that, so keep that in mind if you have a pet that you'll be around later today. The concern is that it's going to cause seizures, right? That can escalate and we can go downhill from there. It has been reported in cases of death as well. The leads from the plants themselves can range anywhere from 0.5 to 5%. So camphor, again, is going to be more warming, and we cap it due to that toxicity concern. So again, there's 3 products that have camphor, all different concentrations. Methyl salicylate or M-salicylate. So salicylate is that byproduct of aspirin. Methyl just means it has a methyl group on it. Okay? We don't need to know OChem other than that a methyl group means one line. Okay? So that's it. It's just salicylate. So salicylate literally is this product. And then we add a methyl group. So how it metabolizes to salicylate is just going to be demethylization. There you go, pharmacy in a nutshell. So it's extracted from wintergreen. It's commonly found in Bengay, icy hot salon POS products. It also has that counter irritation. It also has this mixed activation of V1, so cooling sensation or a warming sensation, and then A1, a cooling sensation. It potentially has COX inhibition. Why would we think that it maybe has COX inhibition? Aspirin, okay, I know we haven't talked about NSAIDs yet, but those all fall into our NSAID category. This one does have quite significant systemic absorption, so 20%. Again, it metabolizes into salicylic acid. We want to avoid it in children due to Rye syndrome. Why else would we want to avoid it in our kids? They just take a bath in it. We can have overdose, and essentially then they get an aspirin or a salicylate overdose. Okay? Which we'll talk about how to manage that in the next hour. What's Rye syndrome? Okay. Kids, bad things. How bad? Brain stuff. What else? What other organs involved? Liver. Okay. Is it just any kid who takes aspirin? No, it's aspirin and what else? Some viral illness, commonly the flu or chickenpox. All right, this guy is another common one. Most commonly we see it in Aspercreme products. It doesn't have a huge market nor a huge background on it. We see this exact same salicylate, and then they just threw this giant thing and then made it into a salt. So essentially your body says, I don't need this part, gets rid of it, and then you just have that salicylate again. It's an organic compound, that salt. Again, Aspercreme, it is relatively more odorless, so if someone's looking for that. It also has that counter irritation, potentially that COX inhibition. It's not well studied or looked at. Benefit is systemic absorption is thought to be low. And again, it does have that salicylic acid component. Questions up to this point? Making sense? We're so excited. How's our little diagram looking, right? We got like A, B, C, D, well, not A yet. We're on the top of A. Or B or C, or D. Okay. All right, we're going to talk about our topical NSAIDs. So in the U.S., we only have one available. Okay? It's going to be our diclofenac products. It's going to work by COX inhibition, which means that we're going to reduce the synthesis of our prostaglandins. So COX is one of our enzymes that needs to take one of our products into prostaglandins. Okay, prostaglandins do what? A lot of things, but mainly in this case, inflammation. Right? So we don't want that. We want to calm that down. So our topical NSAIDs can reduce that prostaglandin synthesis and therefore that inflammation. The systemic absorption at maximum dosing has been found to be less than 6%. Okay? So you guys may get questions in practice. And this is not a testable question because you can say it either way. But you as a clinician need to make the decision. If someone is on an NSAID and they get diclofenac gel, are you okay with that? Okay? Me personally, I'm fine with it. None of my patients are taking max dose diclofenac. Okay? And many of them are taking it wrong. They're taking much less than what they need to do. But I'll have pharmacists that reject my orders when I put them in. Okay? Patients will come back and tell me all that. So we need to find something and then make sure that we're documenting those things appropriately. Despite having a very low systemic absorption, it still carries the same 2-boxed warnings that all of our NSAIDs carry. Okay? So that's the main argument and the main risk with it. Right? Don't use them together because now we exponentially have increased your risk. Okay? So same 2-box warnings. Do we think that someone's truly going to get those side effects with this? Probably not. Right? Less than 6%? Probably not going to be as concerning. So the different products, we have a 1% gel. We do have that available over the counter. It's mainly going to be used for osteoarthritis of our joints. It can be used off-label often for like acute inflammatory conditions, sprains, strains, all those types of things. Dosing we'll talk about on the next slide, but it's going to be 2 grams for each joint above the waist, 4 grams for each joint below the waist. You can do a maximum of 2 sites, so I can do my right elbow and my left knee. I can do both of those sites. I can do both of those sites 4 times a day. So this is where I get into my airline flight attendant type thing, right? 2 grams above, 4 grams below, 2 sites, 4 times a day. Okay, 2 above, 4 below. It's relatively cheap, however, it is our most expensive one, and it just hurts me whenever I do my topicals lecture. This is my 4th one I've done in the last 12 months. Whenever I have to buy diclofenac, but you guys have it. I'm so happy for you guys to try it. We do also have a patch, a 1.3% patch. Oftentimes in our situation, I've never seen it used at Bancy. I know at Gordon they've used it a couple times, but they do have to get a prior auth for it through our processes. There is a solution as well as a pump product. Both of those things are compounded with DMSO. Does anybody know what that is? Any animal lovers, equine folks?
Yeah, Bert was talked about this.
So it can also be, it's similar to like a glucosamine, but often used in vet med. Okay, so it's something that also helps with inflammation. So a lot of the data or question that's out there is it really the NSAID, or is it the fact that it's also compounded with this DMSO? Okay. All right, so the 1% or Voltaren, again, we're going to use it on osteoarthritis, so knees, hands. It has not been tested on things like hip pain. Why wouldn't the makers of a product want to test on hip pain for a topical?
Probably for distribution service area.
What was that? Okay, keep thinking, why won't it help on my hip where on my knee it's going to help? Yeah, that distance. Okay, so I'll have folks who are like, oh, well, the box says, you know, I can't use it on my low back. Well, you can, it just hasn't been studied. And why was it studied? Because they're not going to make a bunch of money on it. The trial that's going to come out is going to say, not as helpful. Okay? But they can try it. Dosing, we actually have a dosing card, so those are the pictures on the top there. We have a dosing card that is in the box. Typically it's sealed or stuck to the side of the box. Everyone misses it every time. Because of that, I literally tell my patients it's going to be 2.25 inches for 2 grams. Why they couldn't have just made it a nice 2 inches, great question. But 2.25 inches for 2 grams, 4.5 inches for 4 grams. So think about a tube of toothpaste, and you're doing 4.5 inches of it. That's for one joint. Where? What joints get 4 grams? Below the waist. Love it. Okay? So when I say, even though my patients, oh yeah, we take it every single day, use a ton of it, yeah, it's really good. But you last filled one tube, 100 grams, 2 months ago. Okay, and you have knee pain. So that'd be 4 grams per joint, so 8 grams per, right, a single dose. They can use it how many times a day? 4 times a day. So 8 times 4, you're done with it in 3-4 days per tube. So think of that when you're prescribing it to your folks or you're encouraging them to get it over the counter. If they take it as it should be, they'd be out of the tube in 3 to 4 days. Okay, 1 tube over the counter, about $10. Okay. All right, diclofenac gel, I always say, looks like ultrasound jelly. So it's clear, it's a little bit thicker, and it's not something that rubs in right away, especially when you have 4.5 inches of it that you need to work with. So oftentimes they need to apply it, let it sit there, let the gel evaporate, and the drug will be absorbed. Okay, don't overly try to rub it in. Don't tightly cover it, and don't apply heat to it. What would happen if we applied heat to it? It's going to go more systemic. Correct, right? So there we're talking about that integrity. Avoid wearing clothes over that area for 10 minutes. Again, that's because it's still going to be gel-like during that time. And then avoid showering and bathing for 1 hour. And why would that be a concern?
Wash it off.
Potentially wash it off, but what else?
Moisture, the heat.
Potentially more moist. Okay, so what happens when the skin's going moist? Systemic, okay. Are we taking cold showers? Not by choice. Not by choice. Okay, so warm showers are also going to do what? More of that systemic absorption, right? We're adding that external heat source. All right, lidocaine. So lidocaine comes in over-the-counter products, it comes in prescription products. Those strengths range from everywhere. The maximum dose we can do over-the-counter is no more than 4%. That doesn't mean that you can't find a 2% prescription product or something. Okay, but nothing more than 4% over-the-counter. As you guys know, it's already going to be a local anesthetic. It's going to inhibit that sodium influx, and so then we have that stabilization of the membrane. The absorption systemically is going to depend on how big of an area, how long they're putting it on, how much they're putting it on, no different than any of our other topicals. However, what's the concern with too much lidocaine? Cardiac stuff, right? Not good, not good. It's going to be contraindicated in our local irritation wound and non-intact skin sites as our other topicals. So whenever we're talking about creams, gels, jellies, ointments, everything except patches, they're primarily going to be used for local minor procedures. Okay, so maybe they're doing some sort of anesthetic lubricant, they're putting an NG down and they just want to numb the throat a little bit, those types of procedures. Or any sort of condition, so minor burns, different abrasions, bug bites, things like that. Typically, you're going to dose it 2 to 4 times a day, but it really depends on what you're using it for. Right? If it's a one-time application for a procedure, you're just going to do that one time. For our patches, there's a couple different strengths in our patches. So we have generics that are either 4 or 5%. Again, 5% must be prescription. Good. These are going to mainly be indicated for postherpetic neuralgia. We use them all the time off-label. All the time. Okay? For neuropathic pains, super common. Max dose. How many patches? 3 patches. You put a patch on, you let it sit there. How long can it stay on there? 12 hours. Then what? Take it off. Then what? You have to wait 12 full hours. Why?
So it'll get taller.
Tolerance, right? So we get this peak. Once that patch comes off, it doesn't just go to 0. So you still get that absorption through those skin layers, but we don't want it to keep absorbing. So we need to have them take the patch off for that 12-hour washout. So oftentimes this is going to look like take your patch all day or take your patch all night. Take it off before bed, take it off in the morning, whichever one it is. You can cut the patches. Let's say someone's whole hand hurts and they just want to do little tiny patches on every single joint. How many pieces can they put on there? So they can put as many pieces so long as it doesn't total 3 patches. Alright. Then everyone's favorite, capsaicin. What other things is this found in? Chili peppers. What military things do we think of?
Spicy chip challenge.
Things like pepper spray, yeah. Bear spray, all those kind of things. Okay. So OTC products are going to be less than 0.15. Pepper spray is anywhere from like 1.5 to 3. Bear spray is in that same range up to about 5. We also have one product that's prescription that's 8%. Okay? So we'll talk about that one and how fun that one is. Mechanism historically was thought to deplete substance P. That's been somewhat reassured, but mainly that's not our primary mechanism. But substance P is one of our excitatory neurotransmitters. If we deplete that, we can't keep sending that signal along. Instead, it's thought that its main mechanism is going to be this TARP-V1 activation. V1 is warming. Okay? Again, it's hot sauce, essentially. It's going to be warming. We're putting it on. Initially, right, you eat a taco, it has a ton of hot sauce on it. How's your mouth feel? That first taco. It's on fire. Okay? After you eat 20 tacos, how does your mouth feel? You don't. Right? You don't feel anything anymore because it has had that chance to work. So with our patients, the first dose that they take, and you guys may experience this today, if you've never used capsaicin and you use it for the first time, what's it going to feel like today?
Burning.
Horrible. It's going to be burning, it's going to be stinging, it's not going to be fun. The 2 times I have tried it with the intention to try to treat my pain, both times I have ended up crying. Okay? Okay. So initially it's going to sensitize. It's going to be horrible initially. The more you use it, the more you can stick with it, you will then have a functional impairment. We will start desensitizing. We continue to do that and we will have a physical or a chemical ablation. We're literally burning the nerve chemically. So that process does take time. Big thing with this one, we don't want to touch our eyes. We don't want to put it on our low back and sweat and it go down. Picture that, yes, we have patients that come and tell me all these horror stories. If you accidentally touch some of it, and if it's on your hands, please go wash your hands. It's one of those things that 3 hours later, you'll feel it when you touch something warm or take a shower or something. You'll find all the little drips that went all over. So again, OTC products, you guys have the option for a cream that is 0.025 today. You also have the solution, which is the highest strength solution that we have over the counter, so 0.15%. Its main uses there are going to be for minor pains with arthritis, backaches. Again, I always caution on back. Muscle strains, sprains, bruises, cramps. Its dosing is going to be 4 times a day, and you need to do it for that 1 to 6 weeks. Why? How long does it take to burn your nerve chemically? It's going to take some time. How long does it take for your nerve to regenerate?
Forever.
To grow back. It grows back. About 3 months. So if you guys have ever, hit your foot really hard, made some nerve damage, it's gonna hurt and you're gonna feel that for a while. And that's because it takes time for that nerve to regrow back and do what it does. So typically our dosing is gonna be a lot of dosing for that time that it takes to truly desensitize and then defunctionalize that nerve. That nerve is going to be burned, if you will, and then we will have to go back and do that process again to burn it again. The prescription product is in clinic only. It's our 8% known as Qutenza. It is 2 prescribed or indicated, FDA indicated indications. So post-herpetic neuralgia and then diabetic neuropathies. Post-herpetic neuralgia is up to 60 minutes that they apply it for, where diabetic peripheral neuropathy is 30 minutes. You can do a maximum of 4 patches. Each patch is $1,000. So whenever my docs come to me and they say, oh, sharing this patient would be great for Qutenza, I say, have they tried over the counter? Have they tried it? Okay. Alright, this top video will keep it playing. So this top video here, we see them, they are wiping, they're wearing gloves. I would strongly recommend wearing a mask and eye protection. When you have someone who's getting Qutenza, you can smell it the second you walk by the room. You don't even have to be in the room. They clean the feet, they cut the patches, they apply the patches. They are clear, they look like tape or Tegaderm. We do also want to make sure that we're pre-treating them with some sort of local anesthetic. So Emla cream or a lidocaine type cream is often applied. When we take it off, you roll it onto itself. The patches come with this aftercare cleansing cream that you apply on and then you wipe off. And that's to help get any of that extra capsaicin that's on the surface. Okay, so it binds with it. The patient needs to avoid heat for a few days, so that means showers, sunlight, hot tubs, all those things. It is going to burn. Okay. Questions on capsaicin? All right, a few more slides here. So compounding. This would be, a lot of folks think that we should just compound some of our oral products and put them into a topical product. So remember that there's no standardized compounding. It's just kind of made up by the pharmacy, by different organizations as to how they build that recipe. The FDA actually did a study back in 2020 looking at the top 20 analgesics and how are they compounded and what is their efficacy, and they really found that it wasn't that helpful. Okay, so taking a muscle relaxant, putting it into a topical, not really that helpful. Very good report should you guys get into pain management or have docs or clinicians that want to be using it to look at that data for each product. So the products that we talked about today, where do they fall into typical guidelines? And the main one that comes out are going to be capsaicin and NSAIDs. Okay. Menthol and lidocaine really aren't called out much in many of the guidelines. There's a 2018 study that found that the main reason for prescribing a topical was because the provider had anecdotal experience. What does that mean?
Their own experience.
Their own beliefs. They used it, they saw how it worked, their patients told them how it worked, they had positive feelings for it. So of all the folks that they questioned, 60% of them said, yep, that's the reason why I give topicals. Okay, 30% of them said it was because the patient asked for it. That's why I'll give topicals. 20% said because it was evidence-based, right? And looking at the guidelines, they're really not really there. 10% said that yes, because of a consult recommended it. So who's going to tell their patients, go and get some salon pops? I love it, it's my favorite. No takers. Why? Come on. One person's like, oh yeah, he loves you, okay? Okay? Or maybe your patient comes in and say, oh, I love taking salon class. Your first question should be, well, which one? Okay? We have some that are strictly lidocaine, some that are low dose menthol, some that are moderate dose. Okay? Icy hot. You guys already know what this is going into. Which one? Bengay. Okay, fine. Instead of just normal Bengay, how about Bengay Sport? Right? These look like they should work. They're so much better. Okay, my favorite one in this list is the yellow one, the bicycle, the vanishing scent. Why do we think that one is a vanishing scent? You guys can't see it. It's a 2.5% menthol. Menthol is typically 5 plus. Okay? So yeah, it is going to be less of a scent because it's less of a product. Okay? Aspartame, we talked about. However, it also ranges from having capsaicin to menthol to lidocaine. Tiger Balm's probably one of my favorites just because of all of its products, it relatively has the same stuff. Okay? But this is my least favorite thing when folks say, oh, I love the red strain, but that doesn't work, so I want to get the black one instead. And it's that 1% really gonna do it for you. All right, Aleve. What do we commonly think of as Aleve? Naproxen is one of our NSAIDs. You guys aren't going to be happy. Is naproxen an available NSAID topical in the U.S.? No. So we have Aleve X, which are going to be menthol and camphor, and then we have our Aleve arthritis, which is diclofenac. Okay, what about Advil and Motrin? What are those typically? Ibuprofen. Is ibuprofen available as a topical? No. Yeah, if you're one that says Voltaren, right, diclofenac. Well, you'd be sad to know that Aleve targeted relief is just all of the things that cause counter irritation. And then our Motrin is going to be our diclofenac. Okay, Tylenol. Should be.
Acetaminophen.
Acetaminophen. Is that available? Did I talk about that yet?
No.
No. So what's in it?
Diclofenac.
Lidocaine and menthol. Okay. Other things that you'll commonly see are going to be the types of indications, right? So arthritis. Both of these products have capsaicin. So if someone's like, oh, I have arthritis, I want this product. Right? Relieves back pain and muscle aches. Both of these are just menthol. Muscle pain and joint relieving. These are the combinations. So regardless of what you guys are choosing, make sure that we're using language that reflects ingredients rather than branding and the indication. And I know I'm pushing on time here. So we're going to talk about our patients, talk with them, use FDA-approved ingredients, limiting our compounding, and making sure that we're weighing those benefits and risks. Lots of different resources for you. As far as for topical trials, we're going to take until, so you guys will have your break during that time. The topicals will be out and around the room to try on, and we'll reconvene 10 after. Okay? Questions? We have our pain pathway, right? So the transduction pathway, prostaglandins are a really big part of that pathway. We're going to be working at the site of injury in that transduction route. Okay? In pain, whenever we have a cellular injury, we get this PA2 that develops from that. That is then released and causes this I can never say it, I always try. Right? AA formation. Okay? That is a component within our cellular membranes. COX takes that and converts it into our prostaglandins. Prostaglandins are then further stratified into different types of prostaglandins, all of which have different mechanisms. some that help protect the mucosal lining, some that have platelet aggregation type effects. So when we inhibit or stimulate those effects, we do see all those changes happen. NSAIDs are going to inhibit that COX enzyme from changing that AA into our prostaglandins. Therefore, we have all of those downstream effects. Mainly, the thing that we're looking for is less inflammation. NSAIDs come in a ton of different preparations. So this is a really beneficial class when we're trying to be creative as far as how to administer a dose to a patient. We have tons of different options. Our main uses are going to be for mild to moderate painful conditions with or without inflammation. Okay, it's going to have antipyretic effects, which means anti-fever, good. Chronic inflammation or inflammatory conditions, so osteoarthritis, rheumatoid arthritis, chronic mild to moderate musculoskeletal pains, and NSAIDs have also been shown to have opioid-sparing effects, which means less opioid use when we use our NSAIDs. Okay? They spare us from having to use our opioids. NSAIDs are also found in some of our eye drops. So mainly those are going to be helpful in different procedures that cause inflammation locally. And then it can also have an inhibition of demyelinosis that happens during procedures. For folks that have eye-related allergies and seasonal allergies that affect their eyes, we can have NSAIDs in those as well to help with that itching and irritation. The COX enzymes are divided into two main types. There is a third type, COX-3. But the main types that we care about with our analgesics are going to be COX-1 or COX-2. So this is a select list. This is not all the available NSAIDs, but the ones that are most common that could be tested are on this list. We have some that are very, very COX-1 selective. So again, it's going to be inhibiting the enzyme at COX-1. So ketorolac is the most COX-1. We have non-selective, meaning it kind of just does both. And then we have super COX-2, where it's inhibiting that COX-2 enzyme. So the naproxen is non-selective. We see many others that are in that non-selective range. And then celecoxib is going to be our most COX-2. Mechanistically, COX-1 is found in our platelet, stomach, our endothelium, kidneys. It is protective. So when we inhibit that, what happens to all of those areas? We stop the protection of our GI mucosal. What's going to happen?
Ulcers.
GI bleeding, GI ulcers. Okay, so what's a side effect if we have a really COX-1 selective enzyme? Or NSAID? GI bleeding. Okay? COX-2 is really helpful because that's the area that's focused on our inflammation. It is inducible, meaning that that trauma needs to happen for that COX-2 to really start working and be present. Found in inflammatory cells, kidney, brain, and bone. COX-3 is going to be that temperature regulation, so this is where we get that antipyretic effects. Our net effect for any of our NSAIDs is going to be dose related. Okay, so at very low doses, we're going to get our antiplatelet effects. So one of our prostaglandins that break down go into TOX. That then works at that platelet aggregation. So really low doses are going to be our antiplatelets. What's an example of an NSAID that we commonly use for its antiplatelet properties? Aspirin, what dose is it? 81-ish, right? Okay. So we can remember that because aspirin is a super low dose when we think of the full dosing available for aspirin. To get pain and to get fever reduction, we need kind of a low, moderate dosing. Okay. And then high dosing will cause that anti-inflammatory dosing. So if we have a patient who's had chronic pain for years, should they be on max dose ibuprofen? Do we think they actively have inflammation going on? Probably not. Okay? So that's a big thing that I'm able to do in my practice is actually dose reduce their NSAIDs to treat the actual condition that they have. Vice versa, if someone has chronic pain, right? I just always have a little bit of back pain, take a little bit of an NSAID. If I have a flare, what do? I take more. That makes sense because I'm getting inflammation. I want to treat that inflammation. When it goes back down and it's just at that baseline, you can just stay at that lower level. So oftentimes when we're treating folks with NSAIDs that have pain, they'll be at a low to moderate dose, and then they can do what during flares? Increase it. Why?
Because it's inflammation.
Because you have that inflammation going on. Good. All right, all NSAIDs, regardless of what their toxical activity is, all of them can cause GI bleeding, and it can also cause cardiovascular thrombotic events. Okay? The mechanism of those are spelled out on this slide. So take a minute, read through these. So GI, the baseline, what normally happens in the GI with those prostaglandins, and then what happens when you add an NSAID to it, and then same thing for the cardiovascular system. So I'll give you guys a minute to read through that, think about it. Once you've read through it, talk with someone that's near you or next to you, and make sure that your buddies understand it as well.
We've kind of talked about already for GI. One of the things is detect the findings. So take medication, especially if so this is all, I've always known about the GI, I never knew about the cardiovascular per se. So COX-1 vasodilase, COX-2 vasoconstricts, and COX-1 has influence on thromboxane simultaneous. So that increases to like aggregation. The thromboxane A. It says thromboxane A2 further allows for effective platelet aggregation, which is, to me, I read that it's COX-1 that's causing that outbreak.
Alright.
Well, that's like that too.
We'll come back together here. Another way to look at this is kind of through this graph here. Okay? So when we look at GI risk, GI bleeding, that's going to increase with our COX-1 selective. What's one of our most COX-1 selective enzymes? Yes, ketorolac. Okay? So if you're going to give someone a bunch of ketorolac, what are they most likely to have? GI bleeding. Okay? Guess what? Ketorolac we actually have to limit to no more than 5 days due to that risk. Our more COX-2 selective are going to have more cardiovascular risk. This is much more of a theoretical risk. There was an agent that was on market. It was voluntarily withdrawn back in the early 2000s. It was about 200 to 300 times more COX-2 selective than celecoxib, and it was associated with more heart attacks and cardiovascular events. So, depending on what's going on with a patient, we may need to rotate them to a different NSAID based on its COX selectivity to determine and kind of do that pro and cons within those different risk factors based on that agent. So looking at GI, something that's separate just from the normal GI risks associated with the COX enzymes is that we have acidic NSAIDs. So ibuprofen is one that is more acidic, and it can cause just by itself topical irritation to the gut lining. Okay, you take it, it's sitting in the stomach, it itself can cause that irritation to the gut, much less the fact that it has that COX-1 selectivity, or the activity. We also know that about 70% of folks that are on or who have an NSAID-induced GI ulcer actually have an asymptomatic presentation of that. The GI risk is going to be outlined with these main factors, and then their overall risk is going to be seen whether they have none of these factors. If they have one or two of these factors, they'll be moderate, and then if they have three or more, they'll be high risk, or if they had a complicated ulcer in the past. Okay? If I had a GI ulcer that made me be hospitalized, even if it's been 5 years, I would still be considered to be high GI risk. Okay? So then when we put this in with our algorithm here, if someone is high GI risk, which NSAID are we going to use? Not ketorolac, we know that. So we're going to use more of a COX-2. Okay, makes sense. All right, what if someone's also on aspirin?
Add GI protection?
Yeah, we want to add GI protection, right? If they're on aspirin, we want to help protect the gut. If they're at moderate risk, but no aspirin use, it's kind of a yes or no, kind of depends on the patient, their risk factors. Okay. If they're low GI risk, if they're not on aspirin, it doesn't matter. Okay, we don't have to do any GI protection. Types of GI protection that we can do are going to be our protein pump inhibitors or cytotec, which is our other one that we are not going to use all too often, which we'll talk about. So our PPIs, they're going to inhibit that pump that is going to be working at that gastric acid secretion. So we're going to be inhibiting that process. Typically, these are going to be dosed 1 or 2 times a day. There are cautions with it in that it does change the absorption of certain things, right? If we change the pH, some of our medications depend on the pH of the gut to be absorbed. Cytotec has different things that look at the prostaglandins itself. So again, we're depleting these prostaglandins. We want to have these prostaglandins in there to help protect that lining. It's dosed up to 4 times a day. The biggest caution here is that it does induce uterine contractions, and so it has a box warning for any woman of childbearing age to not be giving it to them. Okay, so these are some of our options we can use. Okay, so again, going back, if we have a case that says you have an 80-year-old who just had a giant GI bleed, who's on antiplatelets, all of these things, right? We can classify them. We can give them the appropriate GI protection or specific agents. We know which agents to choose for them. Okay? On the flip side, cardiovascular. So cardiovascular, we think of things like hypertension, heart failure, if they've had angina in the past, MIs, cabbages, if they have any stents, or if they're on high-dose NSAIDs, specifically, which NSAIDs? COX-2. Yeah. Okay. So for our NSAID selection, if they have average cardiovascular risk, okay, if they have low or moderate GI risk, we can choose any NSAID. If they have high GI risk, you guys already told me this last time, we're going to pick Celebrex or celecoxib. Okay, we're going to choose that COX-2 selective. When someone starts to have more of a cardiovascular risk factor picture, do we want to give them ketorolac and more of a COX-1? No, right? So we're thinking about those platelets. So we're going to pick naproxen, so our most non-selective Once we get to dual high risk for both, ideally we would avoid treatment, or we can do low dose of a COX-2. Okay, so our higher the dose of NSAIDs, the more of that cardiovascular concern. However, the bigger concern here is going to be that we don't want to have that GI bleed. Okay? We can put both of these things together to get this approach on how we manage these folks that have either GI or cardiovascular. Quick pause. So Scott's coming back. We didn't get rid of them yet. So what if I tell you, you know what, last time Scott actually saw me and he was like, I'm really into herbals, I want to take herbals, and so now we have them on glucosamine and turmeric. What are our concerns? Bleeding, okay. Now what if we put them on an NSAID?
Exacerbate.
More bleeding, potentially. So what approach do we need to do? Either COX-2 or, yeah, GI protection, right? And again, it'll be much more clear if there's any cases that are given as far as how much of a risk do they have either way, okay? NSAIDs all also impact the kidney function. Excuse me. So they all impact the kidney function. At baseline, our afferent arterioles are going to supply that nephron with good fluid flow, and we want to have that dilation to allow for that blood to get in there. Okay. Our NSAIDs are actually going to reduce the prostaglandins that maintain that open. Okay. So we're going to actually constrict that area there. The bottom section has what drug that's actually causing vasodilation of the efferent arteriole? What drugs are there? Not NSAID. What works on decreasing angiotensin 2?
ACE inhibitor.
We got this, okay. So what would be a drug interaction that we run into? ACEs, how? What's going to happen? Yeah, we're going to go tiny here, and then big here, and then what's going to happen to our kidneys? They're not going to work as well, right? Okay. So we can get some renal injury going on. Again, what are the risk factors that are associated? So if they're on chronic NSAIDs, high dose NSAIDs, if they have low volume, heart failure, any vascular disease, diabetes, shock or sepsis, if they have lupus, the older they are, and then again, if they're on those ACEs, ARBs, if they're on hydrochlorothiazide, some of our diuretics as well are going to impact this process. Okay, so renal does not discriminate on the NSAID. Other side effects that we commonly see among our NSAIDs are going to be dizziness and edema. Dyspepsia occurs at about 15%. Those risks are more common if they've had prior GI disease, if they have an H. pylori infection, in which case we often will treat it. If they're concurrently on SSRIs, if they smoke or use alcohol, it can cause an increase in our LFTs, though it doesn't necessarily cause hepatotoxicity. NSAIDs can actually reduce cartilage repair. Why might that be a concern?
You're taking it for it, and it doesn't.
Yeah, we're taking an NSAID because my knee hurts because I have less cartilage, and now I'm going to take this NSAID chronically for the next 40 years, only to speed up that process. So oftentimes, I don't encourage chronic NSAID use, or I encourage low dose NSAID use. Okay. Renal injury and impairment, we talked about. GI upset, again, that's going to be more common with our COX-1 selective and more with our acidic NSAIDs. Hemorrhage also with our COX-1, and then thrombosis or clotting with our COX-2. Folks to avoid it in. If they have significant renal or hepatic, if they have surgery, why would surgery be a concern? Bleeding. We got it. Bleeding disorders, thrombocytopenia, if they're on anechoic. Some chemotherapies can impact that. Pregnancy implantation is a consideration. So NSAIDs, right? Prostaglandins, they help with mucosal protection and mucosal lining. In the uterus, we have lining. If we deplete the prostaglandins that maintain that lining, the implantation is not going to stick. Okay. So in the folks that come in and they're trying to get pregnant, we'll talk about this as a potential concern, especially if they're kind of going through a lot of the different fertility options. Pregnancy in the third trimester. What happens after the third trimester?
Babies.
You have a baby. Okay, is that like easy or is that kind of a traumatic experience? Kind of traumatic, okay? So, bleeding, okay? We'll also talk about some other concerns when we use NSAIDs that are helpful in our kiddo when they're still inside. Caution in our renal and hepatic, asthma, nasal polyps. More common, we'll see this with aspirin, is something that we need to be careful of in folks that also have asthma and nasal polyps. Uncontrolled hypertension, heart failure and edema, ACE-ARBs, history of GI or CV events, and then pregnancy using greater than 48 hours. Again, that's going to be that bleeding risk that we're concerned about. So specifically in pregnancy, NSAIDs should be avoided due to that infertility we talked about. When we're using it during pregnancy, okay? So bleeding, due to bleeding risk, we want to limit it to that 48-hour window in that first and second trimester, and then making sure that we're avoiding it during the third trimester. Another thing that prostaglandins do in our development is they maintain this wonderful shunt, okay? Where do kiddos get their oxygen from? Mom. Okay, when they're developing, they get it from mom. So do they need their lungs?
Yeah. Oh, no.
No. Okay, so we have a shunt that goes and just bypasses the whole lung process, right? We still get blood to the lungs so the lungs can stay alive, but we're just bypassing them. Okay? Oxygen's coming in from mom, and we want to get that out to the body as soon as we can. Okay, so we have this wonderful shunt, the ductus arteriosus, and that we want to keep open. If we give NSAIDs, the concern is that those prostaglandins will go away that maintain that opening. They'll go away and that will close. The concern is that those kids will have pulmonary hypertension. And then we can also see NSAID use during pregnancy, potentially chronic NSAID use during pregnancy tied to kidney injuries. Okay. In the newborn. However, if mom is trying to deliver or is delivering and we don't need her to quite yet, maybe she has a UTI, maybe she's at a site and we need to transport her, we can actually use NSAIDs as a tocolytic. So that means that we're suppressing labor. So if we need to give you a dose or two, so then we can get those lungs developed real quick because it's going to be a preterm. If we need to get them transported, we can actually use NSAIDs right before birth for that purpose. So Maya came back, right? She's the gal who twisted her ankle playing some soccer. She tells you that she's trying to get pregnant, or maybe she is pregnant, okay? And we want to give her an NSAID. No more than 48 hours. But she's trying to get pregnant. Maybe not. Why?
The uterine lining.
Uterine lining, okay. How long does it take from conception to implantation happen? I'll take your guys' word for it. Typically it's about 2 weeks. It's typically what I'm tracking. So during that time frame, right? So a couple days to a couple weeks, we want to potentially avoid it, especially if she's had issues in the past with implantation. What if she's close to delivery? Probably not. We want to keep that blood flowing through the kiddo. We want their kidneys good, all those pieces. Okay? Unless that ankle injury was so bad and now she's intubated and all these things and we need to get her right. Right? Then maybe we want to suppress labor. That would be the only reason. Okay. But for her, no more than 48 hours. If she's trying to get pregnant and we don't want to reduce that implantation issue, probably avoid. If it's just her ankle, what product could we use instead that's not going to have systemic absorption?
Topical.
Topical? For what? Maybe diclofenac gel, right? Voltaren, so it's an NSAID. How much systemic absorption does that have? Less than 6, right? So is there a risk that right, there could be an issue with implantation? Yes, but it's low. Okay? All right, other things when we're thinking about are NSAIDs. So again, COX-1 on the top, COX-2 on the bottom. Some of them are available over the counter. So we have aspirin, we have ibuprofen, naproxen, and then diclofenac, we just have that gel. Some are injectable. Meloxicam has an IV, though it isn't on market yet. And then the half-life is another crazy thing as well to look at. So Meloxicam, right, 20 to 50 hours. So how many times do we think we need to dose that one?
Every couple of days.
Not every single hour, okay? Where ibuprofen, right, has a half-life of 1 to 2 hours. Okay, so oftentimes folks who are taking ibuprofen have to take a couple doses a day. Okay, and that's just to maintain those effects. Alright, other key takeaways, and we'll go through a select handful of these, but ketorolac we need to limit to less than 5 days. Why? Okay, COX-1, not fun, good. We have additional box warnings, which we'll talk about here in a second. Aspirin is irreversible. So all of our NSAIDs are reversible. They work on that COX-1 or COX-2, they work for a little bit, and then they go away. Aspirin, you take a dose, it binds to that COX-1 and it holds on to it for the rest of its life. Okay? Indomethacin does have some unique side effects, CNS-wise, so confusion and those types of things. Ibuprofen does have dosing limits. We'll chat about. Naproxen is the most non-selective. Meloxicam has a very long half-life, like we mentioned. Diclofenac does come in that gel. Meloxicam has another long half-life and is more COX-2, and then Celebrex is going to be our most COX-2. It is relatively considered GI protective, and it does have a sulfa group. However, we are able to still give it despite it having that sulfa group in folks that have sulfa allergies. All right, so with ketorolac or Toradol, again, this is our most COX-1 selective. These are all the other box warnings that it has. So again, it has the same 2 that all the NSAIDs have, cardiovascular and GI bleeding. And then we also see bleeding conditions or concurrent NSAIDs or renal injury, you should avoid it. We see folks that have renal impairment, are elderly, or less than 50 kilos, we should dose reduce. And then the duration, regardless, should be no more than 5 days among all of its routes. So if you give it a day IM and then you get IV access, you do that for 2 days and then you switch to oral. In total, you cannot do more than 5 days of treatment. When we think about aspirin, as we mentioned, aspirin is irreversible. It's mainly going to be COX-1. The TXA2, the thromboxane A2, has that cardioprotective benefit because we're binding to those platelets, we're making them inactive for the rest of their little lifetime. How long do platelets stay alive and stick around? Yeah, 7 to 10 days. Okay? So if someone is on, let's say, baby aspirin because our dose is tiny, that's going to be antiplatelet, and we're taking an NSAID, how do we time them? What's more important, the cardioprotection or the pain relief? Cardioprotection first. So what do we need to take first? Aspirin. Okay, so we need to take aspirin first. That needs to start working. It needs to get those platelets, make them irreversibly bound. Okay, then you can take your other NSAID after. Do you take ketorolac after? Hopefully not. Okay, we don't want to add more bleeding on bleeding. So again, going back to that chart as far as what is their cardiovascular risk, are they on an aspirin for cardioprotection? All right, so let's meet Gigi. She's our 76-year-old female. She's caring for her grandson this weekend and is desiring to keep her general aches and pains at bay. We see she's on a multivitamin, she's on calcium and vitamin D, she's on atorvastatin, she's on baby dose aspirin and metformin. So what are some thoughts that we can do for her? So we can do an NSAID. Which one? Probably more cost too, okay? Or naproxen, right? Kind of depends on what that risk is, right? What's the atorvastatin indicated for? So we have a couple questions, right? All those gears are spinning. We're doing the exact right thing. Okay. Other things with aspirin. So aspirin is one of our main drivers that can cause our aspirin exacerbated respiratory disease, or AERD. Other NSAIDs can cause this, but aspirin by far is the most common. And this just happens when we have respiratory symptoms that worsen when they take an NSAID. Okay? So oftentimes asking, are you using your inhaler more? Are you more short of breath since you've been having this pain and going on? It's very common in folks that have baseline asthma or nasal polyps or sinusitis. Okay? Aspirin is contraindicated in our kiddos. So we already talked about Reye syndrome. So any kiddo plus a viral illness plus aspirin plus something else, right? It doesn't happen to every kid. So they think that it's probably some genetic condition as well that causes that syndrome. It's a very rare and life-threatening swelling of the brain and liver, and it is managed solely with supportive care. Salicylate toxicity has different cutoffs that are going to be weight-based. Okay. Should you guys have a question, you would be told that their level is 180 and that is mild. Okay. When we look at doses, again, this is what we already know, that 80 to 4 grams, okay, 80 milligrams to up to 4 grams is our dosing that we commonly will use in adults. Low doses are our antiplatelet effects, and then as we go up, we get more of our anti-inflammation. Beyond that, in adults, is how we get more of that poisoning happening, okay, that toxicity. In the olden days, we used to dose aspirin by saying, take it until your ears start ringing, and then lower your dose. Okay? So the first side effect that we get is that ear ringing, okay, with those dosing. As we continue to take it, as we continue to get that toxicity development, typically our respiratory rate will increase. That will result in respiratory alkalosis. Children don't always demonstrate that effect. Okay, so they don't always have that mechanism. However, everyone will have sodium bicarbonate depletion. Okay, that will result in a metabolic acidosis. So how do we think we treat it? Sodium bicarb. Okay. And we can have increased temp, heart rate, we can have nausea, vomiting, confusion, all of those things, and eventual death depending on the dose. We can manage it with activated charcoal, oxygen, we can do some glucose, especially if they're confused, but our main driver is going to be that sodium bicarb. Okay. We can try to correct electrolytes and do dialysis. Another interesting thing is that overall, though, there is no antidote. Okay. So we can try to manage it. The best way to do it is with that sodium bicarb. But aspirin is really commonly known to form a Bezoar, which you take a bunch of it and then it just turns into this like bubblegum glob in your stomach. It sticks together, which means that it's going to slowly diffuse drug continuously. If that Bezoar is big enough, or if you're treating them and their aspirin levels continue to increase on monitoring, it's likely because they have a Bezoar. Okay? You can do imaging, you can try to go in and extract it if it's safe. However, the biggest risk when you do that is bleeding. Okay? So it's really that cost benefit there. Aspirin is available everywhere. So here's another, right? I hate branded products, Excedrin. We have so many different options. So I'm really always trying to get what type of Excedrin is it, so that I know, does it have aspirin or does it not? So tension headache does not have aspirin. All right, so little Jackson, who's with his Gigi this weekend, he ingested the remaining quantity of his grandmother's chewable orange-flavored aspirin tablets. So what might we be seeing?
Tinnitus.
Yeah, maybe his ears are ringing. What else?
Respiration.
Respirations are changing. What else? Yeah, he's not feeling so good. What are we going to do?
Sodium bicarb.
Charcoal.
Potentially charcoal.
Monitoring.
Monitor, bicarb. What else? Antidote?
No antidote.
Oh, no antidote. Okay. Okay. Potentially dialysis. Yep. So we could calculate, right, what is his weight, what would be the weight that he would need in order to be demonstrating that, all of those fun things. So should you guys ever choose to work at poison control, this is the exact case that you guys would get all the time if you were working there. Okay? So let's say that we calculated it based on his weight. He would need to consume 30 tablets to get that mild diagnosis. All right. All right, we're gonna finish up here. Like 3 more seconds. Okay. So ibuprofen, also known as Advil or Motrin, it does also have an IV formulation. It's the most commonly used NSAID in the U.S. It is more acidic, meaning that it has more of that local GI irritation to the mucosal lining, just locally, just being in the gut. It does have more CSF rather than plasma concentration, meaning it's going to be more helpful for different brain conditions than it will be for systemic conditions. Okay? These are doses that I will expect that you remember. So under medical supervision, the max dose is 32 grams or 3.2 grams a day. Your over-the-counter max dose is 1.2, and your pediatric dose is going to be 5 to 10 mg per kg per dose. Okay? Ibuprofen is going to be every 6 to 8 hours that you can dose it. So if we have little baby Oliver, he has known influenza A, he's exhibiting general discomfort and is fevering. His clinical course is going as expected. Can we just give him any NSAID? No. What can we give him? Not aspirin. Why? Got it, right? We got some viral illnesses in there. He's a kiddo. Okay? So if we picked ibuprofen, we could go through and calculate it. Right? So if it's 10 mg per kg, just for easy math, he's 8 kilos. You can give him 80 mg.
80 every 6 to 8 hours.
Okay, beautiful. That's it. Simple math. All right. Last one here. So Celebrex or celecoxib, it's going to be our most GI protective due to that COX-2 selectivity, and it does have that heightened theoretical cardiovascular risk. In 2016, there was a wonderful trial done called the Precision trial that showed that at modest dosing, okay, so we're not trying to overdose anyone or give them a bunch, at just general dosing, it wasn't any more or demonstrated any more cardiovascular risk than naproxen or ibuprofen. Okay. As I mentioned, it does contain a sulfa group, but it is okay to give to folks that have a sulfa allergy. Final takeaways. There's no one-size-fits-all NSAID. Okay. You always want to use the lowest dose for the desired indication and for the shortest amount of time to minimize any of those side effects. Mainly what 3 side effects? GI, cardiovascular, renal. Okay. Thorough assessment of risk factors should be considered, and then make sure that we dose adjust or rotate to a different agent if one agent isn't working. Okay. tons of different resources, and then the remaining ones are just, if you're trying to make sense of the NSAID pain pathway, here's a handful of different pain pathways that you can look at. Questions? If you guys still want to try some of the topicals,